Maybe to start, could you please tell us how this telemedicine project all started?
Yes, sir. So basically, back when the crisis started, over a year ago, early 2020, obviously all the news was coming out about COVID pandemics on the way and all this. So I started, researching and reading and trying to learn as much about everything COVID related as I could. And as I did research, I came to find out there was just a huge void of people getting early treatment at home. Everything seemed to be fixated on hospital treatment and the vaccines and all that. So I just decided, I had been doing some telemedicine a little bit, and I just decided, I'm just going to start offering telemedicine consults for free to whoever wants them or needs them, and just start seeing people in all states. Because let me backtrack. President Trump announced that it was legal. There was a law change that allows us to now prescribe in all 50 states, as long as it's COVID-related condition. We are, as physicians, allowed to prescribe across state lines. So I immediately thought, okay, if we can prescribe across state lines, that means I can prescribe via telemedicine in all 50 states. So I just started doing it and just treating people for free. And over time, it sort of snowballed, and eventually my wife suggested, why don't you just start asking for donations? So I started asking for donations, and lo and behold, ever since then, over 90% of people donate, and I've averaged over $50 donation per patient since then, and which is incredible because Teladoc is one of the leading telemedicine companies. They pay doctors an average of around $25 a patient. So we've stumbled upon this great thing that we're basically making more than twice what Teladoc pays doctors treating patients for free. So it's this sort of win-win scenario. And so once that happened, I thought, this is awesome. This is great, because, I look at it now as the politics of what's going on. And I think, there's the old broken system that's clearly broken, healthcare wise. Masses are just, not getting their needs met, and the system's clearly broken. So I thought, I call that the slave doctor system. That's what I call it. And so I left the slave doctor system and became a free doctor. And free doctor means it's free for the patients, but it's also, it frees us up from the corporate CYA medicine, where they tell us which drugs we can, or whatever they try to tell you. We can prescribe whatever we want because we're free. We don't have to deal with insurance denying patients' claims. And so we can practice medicine, this newfound freedom as a physician. I just absolutely love it. It's the best career decision I ever made as a doctor. And all of our team members really, really love it. Our feedback from our patients is so positive and overwhelmingly good. So it's just this great win-win sort of scenario. And so that's how it started. Eventually, of course, I was sort of kind of, feeling like I was the only person doing it. And then, a few other doctors started coming out. Obviously, Dr. Zelenko came out with, his being for hydroxychloroquine and zinc and zithromycin early at home, and certainly I had been using that, and I think that's a great protocol. But eventually, Simone Gold and Stella Emanuel had their, 15 minutes in at the Supreme Court. And so that really gave me a lot of hope when they did that. That was just a great thing for me, because I was kind of scratching my head and almost ready to give up at that point. Because one of the funny things is when you're a doctor and you're telling people you're free, they think it's a scam. They're like, they hear the words free and doctor in the same sentence, and they think, oh my God, this is just some sort of internet scam or something. I'm like, I'm just trying to help people, So when Stella and Simone, went viral, I got in touch with them, and I wound up going up to Washington, D.C. for the second America's Frontline Doctors event at the Supreme Court on October the 17th. And I met, all the other America's Frontline Doctors and participated in that. And I did an interview while we were there with One American News, and boom, within, by the end of the day, I had over 100 new patients. And that's sort of where things took off, because like in the next week, we had like 1,000 new patients. And the first thing I learned was, once word got out that it's not a scam, this is actually real, wham, we're overwhelmed with patients, and I couldn't keep up with the demand. So then I realized I had to start recruiting some other physicians onto the team, and slowly we got other doctors involved, like Dr. Brian Tyson, and Dr. Deborah Hoffman and Mary Rutherford and some of the early team members that joined. So I was chasing the goal of trying to treat patients. I'd set a challenge for all the other doctors in America. I called it my hashtag Physicians Challenge. And the challenge was there's 1.1 million doctors in America. This was back a year ago in March. At that time, there were 1.1 million physicians and only 15 doctors were licensed in all 50 states. And I thought, this is just crazy. How is this? How can this be? And the reason why is it costs around $1,000 to get licensed in one state, and it's around 100 pages of paperwork. So multiply that times 50, it's like 5,000 pages of paperwork and $50,000. So that's why no physicians don't get licensed in all 50 states. So that's something that hopefully eventually will be fixed, because what we really need to solve this to help us out long term is one national telemedicine license, and it'll simplify things so much. But so I went up to America's Frontline Doctors event October 17th. I did that One American News interview. Things snowballed from there. We started adding physicians to our team. I finally got my 50th state. I got all 50 states. Rhode Island was the last state. I got it on the last day of the year, December 31st. Strange thing was I had COVID at the time. I started getting sick with COVID right around Christmas. And I got to my 50 state goal. I couldn't believe I finally got to 50th state. Now, I had been taking all my meds and everything and was feeling better. And I really had thought I'd beaten COVID, and I was kind of riding the high of getting the 50th state on the last day of the year and all that. And, you know, doctors are horrible, patients. I'm no exception. And I got overconfident. I thought I had beat COVID really. And so I stopped taking my medicine. Dumb idea, because about 4 or 5 days later, I wound up in the hospital for a couple of days. I was pretty sick. My oxygen level was dropping into the 80s, and my heart rate was doubling, and I was having syncopal events. So I got really sick with it when I foolishly stopped my own medication regime. But so you learn the hard way, that's something I tell patients is, when you're feeling better, don't stop your meds. Keep taking them, because I learned the hard way not to do that. Anyway, so that kind of set us back for a while, because obviously I couldn't work. And so a couple of other doctors stepped up to the plate to see patients while I was sick. Eventually, I got out of the hospital, slowly started recovering and getting things back on track. And on Easter Sunday, we passed our 10,000th free doctor consult delivered. And we're around 20, we're probably at 23,000 delivered by today. So, it's continuing to grow and do well. We're adding new team members. We're having to change some of our team of lawyers looks at the rules regarding the PrEP Act and what we're allowed to do and what we're not allowed to do. And so looks like, based on what they're telling us, is that we can practice in all 50 states, but if the doctor's not licensed in the state where the patient's at, it has to be a COVID-related health concern. So if you have a sunburn and you're in Alaska, I'm not licensed in Alaska. We have most of the states covered. I think we have about 5 states where we don't have licenses yet. Eventually, we're going to have all the states covered with licenses so that we can treat COVID-related and non-COVID-related both. So I would just say, in general, if any health concerns, if people want to come to us, because my idea of this model going forward is that ideally we would like to spread this to other countries and to the rest of the world, because here's the beauty of this. Super low overhead. You can start telemedicine and seeing patients all over the country for a few $100s. Whereas if you were going to build a real world clinic and try to start seeing people locally, it cost $1 million just to build a clinic. So the overhead cost to get started delivering free telemedicine is very minimal. And that's what has allowed this to do so well. So we're just continuing to grow, continuing to deliver as many free doctor consults as we can. Now, certainly a lot of it's the PR of getting word out and letting people know. And Dr. Peter McCullough is one of our team members, and he's all over the airwaves letting people know about it. So that's taken off. We do need to recruit a few more physicians. Specifically, I want to find a doctor from the state of Connecticut, Massachusetts, Wisconsin, Kansas. Those are the ones that we really need doctors licensed in. So any doctors interested in working with us, just send me your CV, email it to me, benmarblemd@myfreedoctor.com, and we'll see about getting you added to the team. It's really a great scenario for doctors, because when you work with myfreedoctor.com, when you become a free doctor, you can work from anywhere you want. You're not, I felt like my 20 years at ER, I felt like I was a slave to the hospital. I had to live at the hospital. You spend 80 to 100 hours a week stuck at the hospital. So it makes it really hard to have any kind of family life. So now, being a free doctor, you can work from the beach, you can work from the top of a mountain, you can work from the backseat of your car, sitting at home on the couch. You don't have to always be tethered to a hospital is the point. So it's really a great freedom to be able to just work from any location as a physician. And so I really love it. And certainly anybody who wants to come work with us, please get in touch with me.
Thank you for this introductory remark. I'd like to go with you a bit step by step. First, from a doctor's perspective, how does the system operate? You see, how do you get the call from the patient? I understand some information is provided by the patient even before.
Well, I created a very simple, basic. I worked on everything I've done with this. I applied the KISS rules, keep it simple, stupid concept too. So we keep it real basic. We have a simple 3-step system to getting to us. First, you got to go to myfreedoctor.com. You go to myfreedoctor.com and all these instructions are there. But step 1 is you have to download the app we're using. The current app we're using is the Medici app. Now, next month in July, we're actually having our own app built, and our own app should be ready in the next few weeks. It's going to be ready, and we're going to transition over to our own app once we get that ready. But for now, we're using the Medici, MEDICI.MD app. And so patient, step 1 is you have to download the Medici app. Step 2, the Medici app requires you to enter your pharmacy where you want your medications to go to. And this is sort of one of their glitches. They require the patient has to pick it. We can't pick it for them. And then step 3 is the patient has to answer a series of questions that we ask. It's about 10 questions long, which are the standard routine medical questionnaire type questions. What are your symptoms? When did they start? Have you had been exposed to COVID? Have you had any of the vaccines? What are your health problems? What medicines do you take? Have you ever had any surgeries? Are you a smoker, a drinker? What's your family history? All those, drug allergies, how much do you weigh? Those sort of routine questions. Now, the beauty of it is once the patient gets those 3 steps completed, our tech support team kind of helps walk them through it. Now, sometimes we get old people or some people that are not tech savvy. So part of step 3 is if we get somebody who doesn't know how to type or whatever, our support team will call them up and talk them through it and type the answers in for them. So we've kind of we've learned this as we've gone. That's sometimes a necessary thing. And so we do that when we have to, we do it. We get the patients into our system. And then once we have their answers, this is what makes it really, I call it text medicine. It's sort of a new form of medicine. There's a couple of, one of them's Text to MD. They sort of use something similar, but the bottom line is by text, you can treat patients. It's way more efficient. You can actually get the answers, because if I ask a patient, what are your symptoms? They could babble on for 10 minutes talking about the weather. Who knows what they're going to talk about? But when you just ask a question and they type an answer, it's very quick and to the point. So with text medicine, I can treat a patient, a straightforward case, in like 3 to 5 minutes. I can have their prescription sent. So, but with a phone call or a video call, you can't get anybody off the phone in under 10 to 15 minutes. So it's much slower. So the efficiency, now we can call via phone or video if we have to, and occasionally we do that. But I handle 98% of my cases by text only. And, but we do reserve the right. Any of the free doctors can escalate to the phone call or video call at their own leisure whenever they feel like it. So that's up to each physician. And if I have any specific questions to ask them, then I'll ask. But if it's an easy, straightforward case, maybe they're not even sick, they were just exposed to somebody and they're worried they might get COVID, then I can just get on the e-prescribe, send their prescriptions. The prescriptions go through the internet, and then I send the patient discharge instructions. Here's what we sent you, here's what you should take and what you do, keep in touch with us and all of that. And then we ask them, if they want to donate to us. And that's basically, the 3 steps the patients complete, and then the step 4 is completed by the doctor, and then that's it. The free consult's over. And then they go get their prescriptions, and And of course, if they're ill or whatever, then they keep in touch with us. Certainly, the active COVID cases we try to communicate with every day to stay on top of those. We try to help some of the patients. They need IV monoclonal antibodies. We'll send them the links to hook them up so they can get the IV monoclonal antibodies. A lot of the drugs we prescribe, I call it. I've been calling it the COVID cocktail. It's a multi-drug cocktail. The history of viral illnesses going back decades is like HIV, simplest example, treated with multiple drug cocktails. There's like 4 to 6 drugs the patients take, and that's the best way of handling viral illnesses long-term and short-term and long-term. But the issue being people fixate on one drug and they think the one drug's going to be the magic fix. That's just not how medicine works. We always use multiple combinations of drugs. So what we've come to find is early multi-drug treatment delivered at home via telemedicine reduces hospitalizations and deaths by over 80%, probably around 85% reduction in hospitalizations and deaths. The bottom line is we're trying to focus on delivering the early treatment at home and getting, saving as many lives as we can and growing this concept. There's the patient treatment angle is really what we're trying to focus on. I can talk politics all day long, but that's really sort of a side issue.
So here's a follow-up question. What is the practicality regarding the pharmacies, the dispensation of the drugs?
That's a good question. This is one of the weird things is the free doctors have a unique perspective on this that most doctors don't have, since we're prescribing in the whole country. And I would say somewhere between 20 to 30% of pharmacists will not fill certain drugs, specifically hydroxychloroquine and ivermectin. And so for whatever reason, obviously it's political. We have a simple policy to handle that, and our policy works very well. After a few months of arguing with more pharmacists than I have in the past 20 years, I came up with a policy. I just refuse to talk to pharmacists. No, we have a no talking to pharmacist policy. And basically, if they refuse to just simply fill the prescription as written, we just switch pharmacies. We change it to another pharmacy. It takes me 1 minute in the computer. Bammo, I send it to a different pharmacy. I tell those patients, don't go to that pharmacy ever again. And that works real well. Now, one patient I had to change pharmacies 5 times, but I've gotten the patients the meds every single time this policy works. They get filled eventually. There are a couple of mail order pharmacies that we can use to have it delivered. Some people prefer that route. When patients ask for that, we'll do that. There's a couple of those that we use as well.
So one of the criticism I heard, not about your service, but other services, was kind of a slow process. You say this is kind of emergency treatment that is needed for early outpatient treatment. What is the time frame between people realizing, oh, I should call a doctor, to basically get on your website? How much time does it take to get the consult and the prescription? And
that's a good point. What I suggest to people do, the best way to do it is to get the meds before you ever get sick. So if people contact us and they're not even sick, but they're worried about getting exposed, we can send them prescriptions so they have the prescriptions sitting at home, and then if and when they get sick, a month or 2 later, they have the meds already there and they can start taking them when they get sick. That's the best case scenario, because that gets you the meds the quickest when you need them. Now, in reality, what happens for most people is they wait until they get sick, and then they're behind the 8 ball. So they get in touch, they go to our website. We generally, if somebody comes on, they're generally, depends on what time of the day it is. If it's before, 4 p.m. or so, they're probably getting their prescriptions filled that same day. If it's after that, it may be the next day before they get them. But we generally will have, once they log in and get those steps going, our tech support's, our website's open 24 hours a day, 365. So the information's coming in, our tech support's processing it. And so the patient's the doctor's not added until they have all the information. So by the time the doctor gets added, the patient's ready to be treated. So it makes it pretty quick and efficient, so that, if you get on there, now there's always exceptions. Sometimes it takes a little longer. Some people may have to wait a little longer. Like, if we try to address the acutely ill patients first, that's always our priority. So part of what we do is almost sort of like sorting out who's the sickest versus not so sick. And anytime somebody's really sick, our tech support will, send us notices to make sure that those patients are addressed first, and our staff knows to do that. But the people who are just wanting meds for prophylaxis, it may be 24, 36 hours before they get their prescriptions sent or whatever, but they're not, it's a reasonable time frame. We try not to make people wait too long. Now, if they're expecting, to get their prescriptions in 5 minutes, that's not really practical or realistic. So it's going to be, for most people, it's probably, going to be 4 to 8 hours by the time they submit all their information till the prescriptions are at the pharmacy.
So what about the follow-up? What kind of follow-up do you do with your patients?
Well, we basically, each physician has their own patient population, and I kind of oversee all the patients, but we have our tech support team. They flag out the people who with acute COVID, and we have a list that we go down and we make sure, I try to tell each of the physicians, and they know this, that your acute COVID cases, make sure you follow up with them. So I personally, like, for example, if I have somebody with acute COVID, I try to make sure I message them at least once a day, or we can set little time messages that'll ask them, hey, how are you doing today? And so we try to keep in touch with them. Some people, keep in touch, some people don't. So it's hard to force that with people if they don't want to talk to you. But in general, we keep in touch through the website and through text or phone calls. And people can communicate with us through the Medici app by text. They can send us pictures. They can send us test results. One of the other things we do is we do offer legal medical mask exemptions and vaccine exemptions. People that don't want to wear a mask or don't want to take the vaccine, or some people have religious objections or health reasons not to do that, and so we can do that as well. I see it as a liberty, issue. This is America. We're supposed to have rights and freedoms, and every person should have the right to refuse medicine if they don't want to take it. That's sort of, a common American ideal, is that you can't force people to do stuff that's the opposite of freedom.
Okay, you may not know exactly what's happening with all your patients, but I guess you had some hospitalizations of patients. So how does it work? Your interaction with hospitals?
Well, that's sort of an interesting question, because all the hospitals are the traditional healthcare model, and any hospital, you don't get to treat patients in that hospital unless you have privileges at that hospital. It's a legal thing. So basically, if and when a patient goes in the hospital, we can communicate with the family, or even if the patient's still able to get on the internet, we can still communicate with them, but we have no authority while they're in the hospital. Now, if they have meds from home that we prescribe, they can bring them with them. Now, I've had cases where, I had one lady in Texas. She's in the ICU on BiPAP, can't even breathe or talk to me. Her doctors, they wouldn't give her any of the meds we use, and she wanted to try them. And I think patients have the right to try these meds, So I prescribed them to her. Her son snuck them into her, and she made herself. I told her the first thing to do is make yourself a do not intubate, because the people that get intubated, over 90% of them wind up dead. So she made herself a do not intubate, and started taking the hydroxychloroquine and the other meds I prescribed her, and she got out of the hospital 12 days later. So there's been some of that. You wish that didn't have to go that way, but we're just trying to help people the best that we can, and so her son was able to get her the meds, and she survived.
So what about supplementary oxygen? Are you prescribing that?
That one's kind of difficult. Each state's different. Some places we can find home O2 services to get the patients home O2. Some patients, we just tell them that you might want to buy an oxygen concentrator. That's something we're working on, because it would be nice if there was uniformity from state to state, but there's not. If there was a national oxygen supply service, for example, that could do that in every state, then and this is part of what we're doing. We're learning as we go. So part of this is trying to find national other companies that we can partner with that can deliver things our patients need, like home O2, patients that may need BiPAP or CPAP, or just a nasal cannula. And there's other things as far as, that we could, like home health, if we could work with home health, that may be good as well. So part of this is, I guess I'm kind of brainstorming, because the oxygen question is something I've been wanting to solve, because it is a concern, but we haven't really solved that yet in a satisfiable manner that's consistently deliverable to patients, because it's kind of hit or miss. Some patients we can get it to, and some patients we can't.
And in terms of these patients calling, have you established typically at what stage of the disease, at what day of the disease they are typically getting really worried and calling you or contacting you?
Well, it's different for everybody. I would say that certainly there's just the fear. People are so afraid, and that's a large part of what we're doing, is delivering hope. Because there's been, the media fear campaign has just scared people to death, and it's, there is early treatment. We can help. It's not a death sentence if you get COVID. You can survive. You can beat it. We can help you in that process. So the time that I worry about most is in people in the second week of disease, and that's probably from my own experience, because the first week wasn't that bad. The second week was when I went up in the hospital. And a lot of people, patients I see, I tell them, until you're past day 20, you're not out of the woods yet. Once you're into the third week, the odds of you winding up in the hospital go way down. But it's those first 2 weeks that are really critical to, just take your meds, rest, relax, nothing strenuous, stay well hydrated, and, take your meds and keep in touch with us, and we'll do the best we can. And occasionally we get people that are, oh, I'm getting worse, my chest is hurting or whatever. And sometimes we have to say, well, you need to go ahead and go to the hospital, and occasionally that happens. Now, I'll say we've had 22,000 patients now. We've only had 2 deaths that I'm aware of. And both of those were people that wouldn't take the medicine, but,
And typically, what is the profile of your patients? These are people in their 50s, 60s, or you have all kind of age groups?
Oh, it's all kinds. It's all age ranges. We even have some people that want their kids treated now. Teenagers, it's fine, but kids younger than teen years, they don't even really need treatment unless they have some sort of secondary health problem that makes them really high risk. Most 99.99% of children are going to just fully recover without any necessary treatment. So we do have a lot of elderly patients, people over the age of 70, and sort of everything in between. And the elderly population, I love helping the elderly population, and so we do see a lot of them, and a lot of people that are scared, and so we try our best to help them as best we can. And so all age ranges, all demographics, really. The disease, it does tend to affect obese people more, and that's probably the biggest risk group. People with other health, comorbidities, people with diabetes or COPD or heart disease or whatever, but pretty much see a little bit of everything.
And today, how do you get patients? Because these big American frontline doctors events occurred several months ago. How is the word out about your services?
Well, yeah, I was in the America's Frontline event back in October. They're doing a lot of other different stuff. I'm kind of loosely affiliated with them and communicate with them all the time. I'm in these different task force, the COVID-19 task force, the Frontline MDs, the America's Frontline doctors. I'm sorry, what was the end of your question?
Well,
Okay.
are people aware of the existence of your service today? Do you see a
Oh
growth in
yes.
demand, or of course, the number of cases has declined dramatically in the U.S. But how do you get known? You see to the public, given the blackout from the media about early outpatient treatment.
Well, I've done several interviews on One American News that have gotten every time I do one of those, we'll see a spike in the patients. So I've done several interviews in media, and the name's kind of going viral at this point. I think just I get messages from all over the world from people about it. So I think it's pretty much out there now. It's kind of interesting how that works. And I think it's all the key is the words free doctor, because people hear that and just, it's like build it and they will come kind of thing. The Field of Dreams movie, we've built it and people just keep coming in droves. So the patient flow has never really been a problem. We spend $0 on advertising. We don't have to advertise.
But I guess that the real poor people are not contacting you.
I thought about that because I thought, wow, I was so surprised that like 90% of people donate and the average donation is over $50. And I thought about that. And I think what it is to be able to get to us, you have to have a phone or a laptop. So that, or some way to get on the internet, right? So that automatically eliminates like homeless people or what, and that's not something I can control over. I can tell you my personal story. I mean, I grew up dirt poor. I mean, when I was 4, 5, 6 years old, I used to think it was fun to go junk hunting at the garbage. So that was what I looked forward to once a week, was going to the garbage to look for stuff, to treasure hunt. So I'm all about trying to help people that can't afford treatment.
Actually, there is a person who contacted me, and she may be able to ask the question, but she said herself and her daughters wanted to volunteer for your organization. So I guess there is a way to reach out also to shelters, etc. To just say, if you have someone with early signs of COVID, just call us. You see.
Correct. And we've been, part of the issue is I've had a lot of people wanting to volunteer with us, and I've kind of had so many people in touch. It's hard to keep track of everybody, and I apologize if I've lost track with anyone that's listening. But we've had a couple of glitches that we've had to deal with, and now that we're getting things back on track, certainly me getting in the hospital and all that was one of the big ones. But so I lost track with some people then. But now that things are getting back on track and going well, we're going to start, trying to add more. We got to add more tech support. Is the bottom line. We have to add more tech support and more doctors. And the more tech support and more doctors we have, and the more patients we can handle every day. So, anybody that wants to, come volunteer and work with us, just email either me, Ben Marble MD at myfreedoctor.com, or admin at myfreedoctor.com, which is my wife. She helps run everything.
Now, you mentioned you are going to develop, you are in the process of developing your own app. Will that mean that the app could potentially be used in other countries?
I'm fine with that. What we need, and actually I hope that happens. My goal would be 5 years from now, the whole planet has free doctor consult via the internet by myfreedoctor.com, and that we can deliver that. It's sort of as an entryway. We're sort of becoming like a gatekeeper process where people, whether they have the health problem, if they just have a question, they can get an answer for free without having to go sit down at a doctor's office for hours or having to make an appointment and wait 3 weeks. They can just have a simple question and post it, and we won't even charge them, for simple things. And that would save people a lot of time and energy, and it's an efficient, easy system. So I want to apply this concept to the whole world eventually. So once our app's done, yeah, I'm all for that. And if any other countries are interested in working with us, we have to work out the legality of it, because I'm a licensed physician in America, so I'm not licensed to practice in London or Paris or wherever. But so we'll have to have we have to have lawyers to help us figure out what's legal, what can we legally do, what can we not legally do. And so if we get doctors, like if France, for example. If we had doctors that are licensed in France and they want to be on the team, My Free Doctor in France, then we can let them do that. As long as it's all legal, I'm all in favor of it. So that's what I hope we can accomplish eventually long term. I would love to see that happen.
Now realize that in many of these countries, the key drugs you are using are not they are not available, or they are not allowed to be prescribed for COVID.
So, well, you know, they could use whatever's legally allowed. So that as long as we're in compliance and we're legal, I'm all, you know, this is my hope that we can make this happen because it is a simple, efficient system that will help save, you know, thousands of lives, if not more, you know.